Great. Thanks for having me. These are always fun abilities to kind of get out to the community and let people in our area know what's going on with most recent men's health updates. I'll start with a brief introduction. I'm Josh Broghammer. I'm an associate professor at the University of Kansas Hospital, where I practiced urology for the last 16 years. You'll see behind me on my wall a lot of Iowa Hawkeye paraphernalia. I'm originally from Iowa. I went to undergrad and both medical school there, then trained at Wayne State University. And then I went on to do a fellowship at the University of Washington in Seattle. And then I settled here as my first job, and it's been my only job since graduating. And I specialize in men's health with treatments for both erectile dysfunction and stress incontinence. So, one thing this is a great website, the edcure.org. This is a great place. You can text to receive information, or if you grab your cell phone, you can also scan this QR code. This will come up later in the presentation. But basically, this is a great a spot to get information and regarding who's available in the area in terms of treatments and what options there are. Same thing with men who are suffering from incontinence. There's a number of solutions with your bladder that we're able to do, and you can actually score how bad your leakage is to give yourself a rate on the degree of severity. So just grab your smartphone, open your camera, and these will come up at the end of the presentation as well. So as I alluded to, I went to the University of Iowa, both undergrad and med school. I went to residency at Wayne State, and then did my fellowship training for advanced procedures related to incontinence and erectile dysfunction at the University of Washington. I've been in practice here for 16 years. I'm a member of both the American Urological Association, the American College of Surgeons. And there's a picture of me when I was approximately 12. I got to get that updated. I've gotten a little older over the years. First, let's kind of learn a little bit about erectile dysfunction. That'll start us off. Some of this, the end part of the incontinence may not apply to those on the call. So those just interested in ED information can drop off, but we'll get through both topics tonight. So how do we define erectile dysfunction? So what is it? It's the inability to achieve or maintain an erection firm enough to have sexual intercourse. I always like to throw in my own definition as well of it's the reliability, is how often can you get an erection when you want an erection. And so about 1 in 5 Americans will have erectile dysfunction, and those that are 20 years and older. More than half the men who are 40 or older have some degree of erectile dysfunction, and this roughly affects about 39 million American men overall. And so here you can just see an anatomical drawing. We'll get into the anatomy a little bit more, but you can see the flaccid versus erect state with the erection. So how does the erection process work? So when you become aroused, there are nerves that run the penis that become activated. There's a smooth muscle relaxation in the penis itself, and blood flows into the penis overall. And then these additional the blood flow causes the penis to fill and then stiffen. And then the erection starts to compress these emissary veins on the outside, so that blood can't leave the penis, and it enables the penis to remain erect. And, I like to tell my patients, I use a lot of analogies in my practice to kind of make things easier for patients to understand. I tell folks this is like filling a bathtub. So 3 things have to happen. You have to be able to switch the faucet handles and have the water turn off, sort of the on-off switch. Does that work? That's the nervous tissue. You need the hot water pipes, or in this case, the arteries or blood vessels, to start filling the peas with blood, or in this case, filling the bathtub with water. And then you need the drain to close off. And if you have that traps the water in the tub, or in this case, the blood in the penis. And if any of those have any issues, then we start running into trouble with our erections. So what causes this? As we alluded to, it's very common in the United States, in fact, across the world. The top 3 causes are vascular disease, diabetes, and then medication-induced. Vascular is going to be 40% of the patients with erectile dysfunction. Diabetes is going to be 30%. And most of these cause to clogging of the arteries. I tell people to sort of think of erectile dysfunction as a precursor or warning to heart disease, any blockage of your arteries can result in erectile dysfunction as an early warning indicator. Erectile dysfunction can also be the result of prostate cancer treatment, and that's what a lot of the patients who suffer incontinence will be kind of aware of. And then, a precursor to diabetes, heart disease, or vascular disease. This is really the canary in the coal mine. What happens is that when these small arteries in the penis plug up, then larger arteries in the body may follow. The medication, commonly, this 15% that's in here, the medication, commonly we see some certain types of blood pressure medications can contribute. Many of our common antidepressants, so very common sets of drugs that people are on, can impact their erectile dysfunction. And then we know generally that erectile dysfunction have a broad negative impact on your health related quality of life. So let's talk specifically a little bit about erectile dysfunction and diabetes. Basically, according to about 10 years ago, census, of course, every 10 years, the 215 census data, 15.3 million people in the United States had diabetes. Patients with diabetes and ED are less responsive to oral treatments, so they tend to fail earlier, or the oral treatments are less effective. And men with diabetes, erectile dysfunction is often more severe and associated with a decreased quality of life. And then, of course, some patients ED can be the presenting symptom, so quite common disease process overall. Why does erectile dysfunction emerge? Well, 60-70% of people with diabetes have some nerve damage or neuropathy. And again, that goes to the nerves that we talked about being kind of the faucet handles in the bathtub. Does it start the whole kicks the whole process off and gets everything started? So if you have damage to those nerves, you can't sort of flip the switch. And diabetes also accelerates damage to the inner linings of the small arteries. This is where you get arterial damage or blood vessel damage. And erectile dysfunction pills require nerve stimulation and healthy blood vessels to work. As I often tell folks, if you get a little bit of blockage, the pills can still help. They let the muscle inside the blood vessels open up and relax. But if you get a lot of blockage, it's not going to unclog those arteries, and so the pills are less effective in patients who have damage due to diabetes. The factors that may increase ED and men with diabetes: advancing age. There's a statistic that shows if your risk of erectile dysfunction is based on your decade of life, 40% of men in your 40s, 50% in your 50s, 60% in your 60s, 70% in your 70s. If we all live to 100, we're all doomed. Just kidding. But advancing age is part of that. The duration of diabetes, of course, the longer you've had it and the less controlled it is, with poor glycemic control. So that increased sugar level does more damage to the cells, the blood vessels, and so that can exacerbate things. You get more vascular disease. This is the precursor to heart attacks and strokes. Diuretic treatments or water pills, which we sometimes use for blood pressure control, can affect this, and then associated heart disease as well. So kind of a generalized issue with the kind of the blood vessels and how they work. Let's talk about heart disease. The link between erectile dysfunction and heart disease is like I said, it's almost as if there's a canary in the coal mine. So symptoms may develop of heart disease may develop within 2 to 3 years of getting erectile dysfunction. Erectile dysfunction is an independent risk factor for future heart-related events, and then the severity of erectile dysfunction is correlated with the extent of your coronary disease. So blockages in your heart vessels are a size larger than the blood vessels in your penis. So if those early ones start to block off and they've been there for a while and the erectile dysfunction is very severe, it may help predict future heart disease. And then erectile dysfunction, again, canary in the coal mine. You'll hear me say that multiple times. It precedes most coronary artery disease symptoms in 70% of the cases. So the real question we have is, why is that? Well, the reason is the size of the arteries altogether. So blockages in your blood flow generally affect smaller arteries before you get heart symptoms. And so at 50% blockage, the penile artery can start to cause erectile dysfunction. Here you see it 1 to 2 millimeters in diameter. The main artery supplying blood to the heart is 3 to 4 millimeters in your coronaries. Your internal carotids, which are the blood vessels in your neck that supply things to and blood flow and nutrients and oxygen to your brain, are 5 to 7 millimeters, and then your femoral arteries, which are the arteries going down into your legs, are 6 to 8. So this is consequently the order of the most common blockages we see going from left to right. And so certainly the penile artery is going to get affected before any of these other main arteries. Let's talk a little bit about risk reduction. You may reduce your erectile dysfunction risk by improving your heart health. And so this is where, I'm a urologist, but I'm also a doctor. And so although I do surgery on the urinary tract when someone comes in and we see things that we can do to modify to make them healthier, these are conversations we had about improving your diet, eating heart healthy foods, trying to get regular exercise and physical activity, working on weight loss. The longer you carry that extra weight around, the more insulin resistance you get, the more likely your risk for diabetes over time. We also try to get people to quit smoking. That's probably the number one risk factor that patients can intervene on is stopping their smoking. And then reducing stress. We know stress raises your blood pressure. It secretes certain hormones, stress hormones that can induce weight gain and high blood pressure. And so those are all factors we can mitigate. Problem is that sorry, let me go back a little bit. The problem with this risk reduction is once the damage is done, I just want to point out it's irreversible. So if someone comes into the office asking for the pills and they've got mild erectile dysfunction, I really do try to get them to sort of say, hey, we can get you started on the pills before this gets too severe. But what ends up happening is if they don't sort of make some lifestyle changes, get some interventions going, and try to improve their overall health, that mild ED, which may respond to some of the medications, going to progress into more severe ED. So looking at erectile dysfunction and low testosterone, low T occurs when a man's body produces less testosterone than normal. It's going to be more common in men with obesity, diabetes, high blood pressure, high cholesterol, prostate disease, and asthma or COPD. What happens in diabetes is actually men have estrogen as well as testosterone, the same thing as women, but the changes between the sexes are the ratio that those sit in. And what ends up happening is if you're obese, you have a lot of that extra testosterone getting converted to estrogen over time. And so that creates a problem in terms of the more weight you have, the more pounds you pack on, the more conversion of your testosterone to estrogen will occur. So how many men actually have low T? It's about 4 in 10 men over the age of 40. For every 10-year increase, again, as every decade of life that goes by, things get a little bit worse. And so your risk of low T increases by 17%. So what are we going to do for treatment options? If you're diagnosed with low T, we may talk to you about taking testosterone supplementation, either through gels, patches, oral medications, or injections. A lot of this is dependent on the ability of the patient and how they can actually administer some of these. Injections could be quite hard for some people. Testosterone gel, can rub off, and so some people may not want to have the risk of spreading it to their loved ones. And then oral medications. We generally don't do a lot of oral medication in the United States because testosterone gets passed through your intestinal tract, and then your liver has to metabolize your testosterone, so there's a risk for liver dysfunction. Let's talk about erectile dysfunction and prostate cancer treatment. So erectile dysfunction from prostate cancer treatment is essentially due to anatomy. And the nerves and some of the blood vessels that supply the blood to the penis are very close to the prostate. We call this the neurovascular bundle. You can see here in this diagram, we've got the bladder, we've got the urinary sphincter, and here's the prostate sitting here. The neurovascular bundle runs underneath. And when we remove a prostate, we try to leave those nerves intact, and then we hook the bladder directly to the urinary sphincter once the prostate itself has been removed. And so any damage, sometimes we don't always try to save those nerves if the cancer looks like it's aggressively invading into the nerves themselves. sometimes those nerves need to be removed for the sake of getting all the cancer out. And so that's one of the risk factors of prostate cancer treatment, including surgery. Radiation's not safe either, as the nerves are sitting close to the prostate where most of the radiation damage occurs. Uh, let's talk a little bit about sexual dysfunction after prostate cancer treatment. It generally affects between 25 and 75% of men. Where you start off before the surgery um, really affects the um, risk factor you have afterwards. So men who have minimal minimal erections after or before prostate surgery are unlikely to have any improvement. In fact, they're likely to be worse. Men that are borderline might see it exacerbate, and a lot of times we're able to rehab men that have great erections before prostate surgery, depending again on how much we save those those nerves. But even with nerve-sparing prostatectomy, erectile dysfunction may last a year or more after surgery. And so those are patients where we sort of say, hey, the body's had a chance to heal. The patient's done their rehab, and if things still aren't working, then we try to intervene in some way. In addition, sexual dysfunction of radiation affects up to 50% of men. So radiation affects decreased blood flow and damage to those blood vessels we talked about earlier. Let's talk a little bit about Peyronie's disease. Peyronie's disease is kind of becoming more well known. There is a medication on the market. You might have seen the commercials on TV for a bent carrot. That's done a lot to educate people on Peyronie's disease, but what that is a fibrous scar tissue inside the penis causing curved and painful erections. And so what happens is the scar on one side begins to pull the penis upwards, is the typical presentation, but it can be right, left, or down. The side and downward are less common. And those complications related to that um, prevent the person to have intercourse simply because of the angulation. It's hard to have appropriate penetration with the penis if it's bent severely. It can cause pain to your partner and cause a lot of stress related to that. It's also oftentimes more difficult to maintain an erection due to alteration in the blood flow. And there's a lot of stress or anxiety about how it looks. People are worried about or ashamed or worried about ridicule. And so it's very disheartening in men who have this, and emotionally, it's very taxing. About 70% of men will have anxiety or depression related to this. A couple different treatment options. We have a medication called Xiaflex. That's the carrot commercial that you may see on TV. In addition, we have surgical options to correct this. You can get penile implants if you have Peyronie's disease, but you really want to reserve those for patients with both erectile dysfunction and Peyronie's disease on both sides. We have found in the past that sometimes we see people who will just get penile implants. They'll say, hey, my penis was hard, there's no problem. But they'll get a penile implant in when maybe perhaps we could have just straightened their penis with good erections. But if you have both, penile implants definitely part of your armamentarium. uh, there's a few things out there that the American Urological Association should be considered investigational. These are treatments for erectile dysfunction itself. However, they don't have good scientific rigor or study behind them. They don't have enough data to have made our guidelines. And so looking at this, um, we talk about extraportal shockwave therapy. The idea is this is little shockwaves. Usually these are either office-based or handheld devices that sort of create, I tell people it's kind of creating a mini earthquake in your penis. The damage that's in there causes new blood vessels to kind of grow in is the theory behind it. But it's very non-specific and has data that's kind of all over the place. Some trials show some success in the right patients. Other trials don't show much success. So the therapy is not, in my opinion, ready for prime time. Intracavernosal stem cell therapy. So stem cells, essentially, we used to think these only existed during our fetal development or being obtained from the umbilical cord at birth. But stem cells are cells that are have the capability to grow into any other type of cell. So they could become a muscle, they could become skin. So lots of options um, for the stem cell. The idea is can we theoretically harvest these stem cells, inject them in the penis, and get them to regenerate either blood flow or repair damaged nerves? Um, Essentially, there was also concern that if you didn't have your stem cells saved when you were delivered, that there was no source of stem cells. All your cells were essentially turned into what they needed to be, and then couldn't improve. And it turns out that what the reality of that is that these stem cells actually can be derived from fat. The last thing we have is platelet-rich plasma. What we do is take some blood out of a tube. We then put it in a centrifuge where it spins really quickly. The blood cells fall to the bottom because they're so heavy, and that leaves supernatant, or the stuff on top, and that's basically a very rich plasma containing platelets, but also growth factors and things. The idea is injections into the penis will help foster, again, new blood vessels growing in. So the problem is none of these are really, and you might hear that called the Priapus therapy or Priapus shot. The problem with these is they're not ready for prime time. They don't have enough data to show they actually work. And so the jury's still out on these. And so the American Urological Association says you shouldn't have to really pay for these therapies or have minimal payment. The goal is simply to sign up for clinical trials. Let's just go through a few treatment options you might be familiar with. You have oral medications, you have injections, you have a vacuum erection device, you have your urethral suppository, and then you have penile prosthesis or implant. So the oral medications, again, increase blood flow to the penis. They're pretty effective in the right patients. 68% of the cases they'll work. You can have them affected by food. I tell people if you drink alcohol, you might feel yourself feeling a little bit more woozy if you drink alcohol on an empty stomach versus if you have a full belly full of food, the absorption of the alcohol is much slower. And so what we see in this case is the same thing with these pills. If I take the missus out for dinner and have a large meal, you might find out that the pills that you took that evening may be a little slower to work because they're getting blocked by the food itself. Most common side effects are going to be headaches, facial flushing, upset stomach. These are all side effects related to um, blood vessels opening. So headaches, the blood vessels in your neck open up. You can get low blood pressure, you can get headaches. Facial flushing or feeling red, that's from your skin cells opening up, and you can get sort of sinus pain as your sinuses open up, and you can get kind of a runny nose. If you're taking alpha blocker therapy, the most common of these is going to be tamsulosin that gets prescribed these days. These are medications that open or relax the prostate to help you urinate better. And you want to be careful with these because they can open up your prostate, but they originally started as a blood pressure medication. So they can also open up your blood vessels. Now you come in and add the pills in, they open up the blood vessels too, and you get an unsafe drop in blood pressure. Same thing with the nitrates. These are the same as like nitro tabs, or if you take other nitrates for your coronary artery disease. About half of men who take some sort of oral medication will give up on pills, or they eventually stop working when they've worked for a while. Again, the pills aren't unclogging those arteries; they're just allowing to relax. So if you keep accumulating more and more blockages over time, then you'll run into trouble where they'll not be as effective. Men in diabetes are 2 times more likely to move on to other treatments, again, for reasons we talked about earlier, with just the pills being less efficacious. Intracavernous, or intracavernous, excuse me, injection therapy. These are the shots. How does it work? You inject medication directly into the penis, and you get an erection within 5 to 20 minutes. It's pretty effective. We use this usually when men have failed the pills. About 40% of men will stop it, typically within 6 months. You can get some problems with prolonged erections, penile pain. The needle poking can do trauma or damage, creating scar tissue like Peyronie's disease. You can get bruising or bleeding just like you would if you got your blood drawn. So those are all sort of common things. The most common reason people want to stop is it just doesn't work. It doesn't give you good erections, and so the erections aren't effective. A certain percentage of people will have pain with these erections. Not only is the needle poke, but sometimes one of the medications we use called alprostadil can cause a burning sensation. And then, hey, I just don't like injections. It's a pain in the rear. I've got to head to my fridge, pick up a bottle, pull some out, try to get the dosing right, and they just think that's a lot of hassle. So that's one of the things that in the right man, it'll work. But you got to pick the right person. Then you got to have somebody who's willing to do the shots. So withdrawal rates are relatively high amongst injection therapy patients. Um, Vacuum erection device, or VED. How does it work? You get a vacuum pump. It pulls blood into the penis. Uh, you'll see this tube here going over the penis, and this creates a low pressure. I always tell, again, my analogies. I always tell people that this is like the sci-fi movies when the bad guy gets blown out the airlock, or when the alien gets shot out into space. It's because the low pressure in the penis, the blood pressure is higher, so blood will flow into the penis, giving an erection. In order to maintain that erection, once you pull the tube off, the pressure differential goes down. So you've got to have a way to hold the blood there, and that's what this constriction ring is. It's really hard to see with this kind of red color, but the idea is that squeezes down and traps blood in the penis. It works in satisfaction rates are about 68 to 80%, depending on the patient. It does cause some problems though. If you look at the rubber band, it could get relatively tight. It may block your ejaculation. You can get bruising, discomfort, pain, or penile numbness or coldness from the constriction feeling, um, compressing both the nerves. And then the most common reason for discontinuation is, hey, it doesn't work. You're gonna hear that theme a lot. If it doesn't work, we got to move on to something different that's gonna work, because we've got plenty of options available. And then pain or discomfort's upsetting to patients, and so they'll generally stop. Uh, Urethral suppository. What happens with this is you get a uh, basically you urinate, empty your urethra tube, and then there's an applicator stem with this little device that shoots a pellet or a BB in there, and then that dissolves in the urethra as a way to get it there, and then takes 5 to 10 minutes to get an erection. Success rates are about 40 to 66%. Not great, but usable in certain patients. I tend to reserve this for patients who would be good injection candidates, but maybe actually have a true fear of needles. And I always talk about that a little bit. You might come in and say, "Hey, doc, needles aren't my thing. I don't really like the idea of injecting my penis." And the reality um, it's not that bad overall, but you're never going to convince that to someone who is terrified of needles. And so this is a good substitute to compensate for that. The most common side effects are going to be pain in the genitals. This can cause a burning sort of sensation as it dissolves and goes through the urethra. Minor urethral bleeding and spotting, that's from basically sticking the probe in and nicking the areas. Low blood pressure, dizziness. Again, these open up blood vessels, and so you could lose some blood pressure here. Whoops, sorry, hit the wrong button there. My apologies. One sec here while I hit this again and get this reset up. There we go. You would think after the pandemic and doing all these talks on Zoom, I would have this dialed in and figured out, but nonetheless, here we are.
Dr. Broghammer, we've all been there, unfortunately. It's no
I
matter how many times you do it.
Yeah, it always takes one random button. If
I
only I
know.
had my 12-year-old here.
Yeah.
So, all right, I think
Perfect.
we're back on board.
Yep.
Um, Yeah, I'm gonna wait on the chat. I just see somebody asked a question that we'll kind of get to here. in a little bit, but I'll finish up this part of the talk and then we'll move on to some ED related questions. So urethral suppositories, as we talked about. Um, most common reasons for discontinuation are insufficient erections, burning or pain, as I said, and then the desire to switch to a different ED therapy. I haven't seen natural return of erections really occur in patients. That would be sort of miraculous, but that's what happened in one of our studies. You've got to refrigerate these suppositories. You don't want to let those heat up. And then about 75% of patients will drop out if they've had their prostate removed after 15 months. All right. All right, I'm not crazy. My screen was freezing a little bit here. All right, so penile implants. This is kind of the last sort of top of the pyramid or tip of the spear. If you've gone through the medical therapies, and it's not a requirement to go through all of them, but commonly we have people try to work through and try to do simple things first, because surgery is surgery, although it can be done very safely when planned. We want people to realize this is the decision they come to, and they decide this is what I need. So what happens is, how's this work? I tell people this is like mixing a cocktail. You've got one glass here called the reservoir or storage tank, and then you've got the cylinders here. And what you're doing is you're transferring fluid back and forth between these. So you squeeze the pump, and this is like X-ray vision. One of the questions I always get from this drawing is, hey, is this stuff on the outside? And the answer is no, it's all buried underneath your skin. So you can work out at the gym, change clothes at the pool. No one will notice or see that you have a penile implant in. So you squeeze the pump here in the scrotum, that transfers fluid, moving from the reservoir through the pump into the cylinders. The penis becomes erect. There's a deflation button that's associated with it. You push that button, and then you squeeze the penis, and that pushes the fluid back into its storage tank. 98% of patients reported erections to be excellent or satisfactory. Remember, many of these men aren't getting erections, until they have this operation. And then most common side effects are going to be postoperative genital pain or infection, and then mechanical malfunction. At 7 years, it's important to note 94% of these are still fully working. I believe at 9 years, it goes to roughly 70%. I tell people you get a good 10 years out of it. It's like a car. The more miles you put on it and that sort of thing, the more you'll have to have these replaced. But they're highly effective. 3 types of implants. Different patients require customization or different implants. The 3-piece is going to be the sort of, I wouldn't say best implant, but most commonly used one. It's sort of the workhorse of the unit, and it's the most common, sort of most natural and satisfactory out of the 3. What happens is that there are reasons why this could be difficult in certain patients. And so, especially if you've had a lot of abdominal surgery, this reservoir storage tank has to go next to the bladder. But say I've got somebody who's a war veteran who was injured at the time and had to have surgery on their abdomen. Later on, their gallbladder went bad. They had appendicitis. They ended up having colon cancer. And so they've had 4 or 5 operations. Maybe they went on to get a kidney transplant, something where there's a lot of surgery in that area. And the problem we run into is that creates a lot of scar tissue. And so when we don't want to implant this reservoir, or we think it's unsafe, we'll often move to a 2-piece implant. Now you might say, well, gosh, where's all the water if that tank's there? Why don't you just use that all the time? And what happens through here is the water is stored in the back of the cylinders, kind of in a reserve tank back here, as well as the fluid that's in the actual pump's a little bit larger. And the way you deflate this one, instead of being a button, you actually bend it in the middle, and that's able to transfer some of the fluid. So some of my older patients, that bending mechanism is a little harder for them to do with their hands. And so that's the other reason I really like the 3-piece, is that most everyone can kind of operate it. There are people, however, who probably aren't a great fit for either the 2 or the 3-piece. And those, in my practice, and realizing other people vary, are going to be people that have problems with functional use of both hands. Bad diabetes, you can't feel your fingertips. You have a issue where one hand doesn't work, say you've had a stroke or nerve palsy where one hand is unable to grasp or move, pinch, then the malleable implant may be more something that up to your liking. The difference between this one is there's no fluid moving back and forth. The shaft is kind of always hard, and I tell people it's like a reading lamp. When you want to use it, you can bend it up, and when you don't, you bend it down. But it works kind of like a reading lamp in terms of its flexibility. But it's great for people that have just one hand that's functional. Uh, and so it really offers an option for, a bevy of patients who may have complex medical histories. And this is where the custom fit part's really useful. So looking at the three-piece penile implant, it's the most commonly implanted one. And this one, so it's the most implanted. It's the only one with built-in antibiotics. So one of the things we discovered, if we have coatings on the outside of these implants, they've drastically reduced the rate of infections, cutting them nearly in half over the course of time. And this one's the most designed to mimic a natural erection because when it's fully rigid, when it's inflated, it's also naturally flaccid when deflated. And that's because all the extra water during the inflation is hidden in this reservoir. They've been in use for a long time, 45 years, and more than 500,000 men have received a penile implant. Now, depending on the age of our viewers, I always like to harken back to Phil Donahue, if you can remember the days before Oprah, even, or Ellen DeGeneres, or any of the other kind of big name talk show hosts. Phil Donahue actually had a urologist on back when I was in high school, 30 years ago, talking about penile implants, and that always stuck with me because I thought, man, that's crazy that these things exist. I've never heard of them until I saw them on that show, and then here years later, not because of that episode, but I just happen to be, sort of an expert doing a lot of these. Here's a video we're going to show you of how the penile implant works. It's going to show you an animation of some of the fluid moving through. This is just a basic understanding. It's not an instructional guide. And then, always talk to your doctor as well as get the official paperwork on how this works. You're going to see the gentleman reach under here, grab the pump, and as he starts to squeeze, fluid's going to move from the reservoir down through the pump into the penis, creating an erection. And then when he's done, he's going to push that release valve, and some of the fluid's going to flow back into the storage tank. And this is how we have, a highly effective device. U.S. Federal law prevents this device to sale by or on the order of a physician. So you have to basically have doctor's approval to get these devices. So what should you expect? Let's say we go to a penile prosthesis and patients come in and usually we go through lifestyle modifications, improvement in the overall health to try to just get them to be healthier patients. But we go through the pills, we maybe try the shots, and then where do we go from there if those don't work? And that's where the implant comes in. When you have the procedure, it's an outpatient procedure under anesthesia. It's a small incision in the scrotum or above the pubic bone. I do penis scrotal, so mine's a small incision, but yay big on the scrotum. And generally, a few days, you return to your regular routine, and you have light activity. We don't want you doing a lot of lifting or straining because we don't want you to break the incisions open. 4 to 6 weeks after, or I'm sorry, usually it's 4 to 6 weeks before you use the implant for sexual intercourse. So there's a recovery period. We want all your incisions to heal. We want everything to seal down. Cost, insurance coverage does vary quite a bit for erectile dysfunction treatment. Incontinence treatment's more commonly covered by insurance, and then coverage may be available under Medicare and Medicare Advantage. Don't let it be a barrier. We can try to work out ways to make it more affordable. Talk to somebody like myself, a specialist, and we can work with your insurance company manufacturer and get your benefits all straightened out. And then ask your specialist about financial assistance. You may be eligible for payment options through a program offered by the manufacturer. And so, it's important to make sure that these devices are expensive, but it's important to make sure that you can make them affordable. And of note, if you have usually typically the VA will cover these. So if you have veterans benefits, as well as being on Medicare, if you're younger, that commercial insurance, in my opinion, around the Kansas City area is probably about 50-50 whether they cover or not. So So what have been saying about their implant? They're just examples of two kind of common patients. We've got John on the left. He's got diabetes and high blood pressure. He's had a penile implant for 14 years, and he says it was the first time I ever had a surgery. And honestly, I was nervous. Very common statement, but recovery was pretty easy for me. Having the implant's been really good, great. I got back to my life. I'm looking at with Cliff, who got diagnosed with prostate cancer 10 years ago. He got a three-piece implant. What I've come to find out is that you're not alone in this. There is light at the end of the tunnel, and that may give you and your partner a new outlook on life and your personal relationship. So, success stories. Um, just talking about the benefits of penile implants. They're 97% proven satisfaction. If you talk to the partners having sex with those men with penile implants, they have a 98% partner satisfaction with the three-piece implant. It's clinically proven to reduce the risk of infection with the inhibisome coating. Typically, it's covered by insurance or Medicare. They're long lasting. They're permanent. They're concealed. All positives from that perspective. They're durable, and like I said, almost 90% are in use after 10 years. They are very natural. They're designed to maintain the natural appearance of an erect and flaccid penis. They don't interfere with ejaculation or orgasm. Another one that people always ask is, how much numbness will I have? And the answer is really not much. We're your numbness, or sorry, your nerves are intact after the surgery, so we shouldn't alter your numbness in any way. And then spontaneous. So, you can have sex when the mood strikes. You don't have to sit and say to yourself, oh man, I got to go home back to my place and get my injections, or forgot my medications on that cruise I was taking with my wife. So you want to be able to have the flexibility and ability to use these whenever they're available. Any surgical procedure, there's possible risks. There are risks involved with any surgery. Not all patients candidates are candidates for penile implant. So discuss the risks and benefits of this with your doctor. Some risks of penile implant include spontaneous erections, as well as other interventional treatment options. Um, there may be mechanical failure when the device breaks. It tends to get the wear and tear of moving back and forth creates a crack in the tubing, which the fluid leaks out. At that point, if you want you may have to consider another surgery if you want to replace the implant. One of the common questions they get is, doc, I'm older now. I live in assisted living. My wife passed away. I don't ever use my implant very often. And when I went to go use it the other day, I went to pump it up, and there seemed to be no fluid in it. I have a lot of heart problems. I'm not doing well. I'm on chemotherapy for cancer. Do I have to get an operation to fix this? The answer is no. If these mechanically fail, they don't cause any harm if we leave them behind. So generally, we don't. We sort of don't mess with them if the patient's too old or too frail or too sick to move forward. But they know having an implant that's not functional is still safe, and so we don't have to do any emergency surgery or anything like that. Of course, you get pain associated with healing. Find me an operation that doesn't occur. And then you get pain with diabetes, spinal cord injuries, or open sores can increase your risk of infection. Um, and then there's a 1.2 to 2.5% risk of infection with the penile implant. So very, very safe procedure overall. So just kind of erectile dysfunction summary. It's a common problem and it's associated with other conditions. There are a variety of treatment options. Implants could offer a long-lasting solution. And then I recommend you go to edcure.org. There at the bottom of the flyer for more info. Brittany, do you think we should take some questions now or just kind of continue on?
Totally up to you. Typically, we finish the presentation and then do
Okay.
question. Yeah, let's just do that.
Okay, perfect. All right, this
Thank
one's a
you.
little bit quicker for the folks on, and then we'll kind of hit all the questions. So the next we'll talk about male stress incontinence. What is it? Also known as bladder leakage. Stress urine incontinence when a person cannot stop urine from flowing out of the body when moving. And typically, we talk about stress. It's not psychological stress or emotional stress. It's physical stress. Laughing, lifting, bending over, doing yard work. About 500,000 men will suffer this across the world. Nearly 1 in 20 men over the age of 20 have had moderate to severe incontinence of any kind. And so it's important to figure out, what treatment options we have for this. All right. So how does the urinary process work? So we've got your bladder, which stores urine. What a lot of people don't realize is this is actually a muscle that pushes your urine out. And then urine exits via the urethra or your peeing tube. The sphincter muscle surrounding the urethra squeezes down or holds our urine in. In this case, when you're actually peeing, it's got to relax. Muscle contraction will normally be able to keep that urine in the bladder, but when this relaxes, urine's able to flow through the urethra and on out. And remember, the bladder's a muscle pushing it out. Um, so we stress incontinence or leakage with coughing, laughing, lifting, straining. It typically correlates with prostate cancer surgery. Up to about half of men will report leakage immediately following surgery. Our goal is many men will leak. We hope through physical therapy and recovery in time that many of those men will become dry, but still about 9 to 16% will have leakage after 1 year. Um, this could result of neurologic disorders. So just because you got prostate cancer doesn't mean you don't have a bad back already or a pinched nerve or things like that. Enlarged prostate surgery, if we do a TURP where we go in and we shave out the inside of the prostate to open up a channel so there's better ways to pee. We have radiation damage. We have pelvic fracture, all sort of other causes related to stress incontinence. It definitely affects quality of life. Studies have shown that people suffering from stress incontinence are more depressed, psychologically distressed, emotionally disturbed, and socially isolated. When you're wet, you don't go seek out, trips on vacation, visiting family because you're worried you may have an accident. And so it's really a huge impact. You're not able to work out as much. If you go exercise heavily and things like that, you end up with problems with leakage. So how does this work with prostate cancer treatment? You've seen this before. There's approximately 70,000 prostatectomies performed each year. 96% will have persistent post-prostatectomy incontinence. And this is because there's various things that can occur when you remove the prostate. The urinary sphincter here, if it gets damaged, may not be able to hold things. In addition, not on this drawing, is something called your bladder neck, which is the junction between the prostate and the bladder. That's another sphincter muscle, not on this drawing, that will help hold back urine. Short term, people try to figure this out. Hey, I'm leaking all the time. What do I do? I'm gonna reduce my fluid intake. I'm gonna go to the bathroom in regular intervals. They might do physical therapy to help recover right after surgery or Kegel exercises. Biofeedback, we can sort of hook you up to some wiring and see what muscles you're squeezing and are you doing the right ones and are they behaving like you're closing them strongly. And so we have some information based on that. Coping mechanisms, people can use pads, diapers, catheters, and penile clamps. These are all temporary solutions, as none of them will, last forever. And they get expensive. I was amazed how much a box, I think a box of Depends is like several $100s once you get a large case of them. And they're not covered by insurance quite often. So this is a huge economic burden on a lot of our patients. So coping solutions, I already said it, are expensive. They can become problematic, and they're certainly a nuisance. The absorbent products are costly, bulky. Oftentimes people leak around them. Catheters are uncomfortable. They can cause urinary tract infections anytime you leave something in the bladder, or it becomes kind of like a ladder for the bacteria to climb up and cause a urinary tract infection. The penile clamp can control leakage, but it has to be taken off often. So this is a clamp that if you leave it on for too long, you actually cause problems with circulation and pinched nerve. 5 pads per day for 5 years is worth about $7,000. I'd much rather take a vacation on that kind of money than continue to buy pads. So long-term solutions, we'll get into a couple of these here. We've got the male sling system. This is nice because undetectable to others. A high success rate in patients with mild to moderate stress incontinence. Most patients are continent immediately following the procedure. Operates on its own to restore continence. You don't need any additional procedures performed, and then 92% would undergo the procedure again. So how does this work? As you can see here, we have the mesh of the sling going underneath the urethra. We have a wing on either side. So what we do is we're able to pull this up like a hammock and reposition and support the urethra. what I like to say is your urethra wants to pinch across one another, but a lot of times after prostate surgery, we'll see a fall in the pelvic floor, and by putting this sling in, we're able to pull it back up. And a lot of people would recommend this 94% to a friend who's in a similar situation. The artificial urinary sphincter is another option. This is the gold standard. This has been around since the late 70s, early 80s. In fact, the current design hasn't changed a whole lot since the 80s, other than adding the antibiotic coating. It's proven, it's discreet, it's undetectable to others. It mimics how a normal urinary sphincter works, and that most men with a weakened sphincter can achieve uh, muscle incontinence. So how does this work? It's going to look very similar. There's a storage tank or a pressure regulating balloon in the abdomen next to the bladder. This one is a little bit different than the penile implant. It's always turned on, but you turn it off to urinate, and then it resets itself. So it's not a light switch that you're flicking back and forth. It's always on, but you turn it off to pee. So you squeeze the pump, that puts fluid into the reservoir. It suctions out fluid in the cuff. The cuff then opens. You got a couple minutes to basically kind of empty your bladder, and then it'll turn back on its own. Here's just some animation of that. Same warning. This is intended to provide basic understanding of how the implant functions. It's not intended to be an instructional guide. And then talk to your doctor or your physician. So when the patient needs to urinate, they squeeze here. It pushes fluid in the balloon. The cuff opens, and then they're able to urinate. And then over time, the balloon starts to push the pressure back, fill up the pump. Pump then fills up the ring. And then again, it's restricted device by federal law, so you have to have it on the order of physician. So what to expect? Also an outpatient procedure, small incisions, approximately this big on your abdomen, maybe a little bit bigger on the belly, or on, excuse me, on the perineum, the space between your scrotum and your anus. Takes a few days to return to non-strenuous activities, and we're going to leave this turned off for about 4 to 6 weeks. What ends up happening with this is you get a little bit of swelling down in the scrotum. It's hard to find that pump to squeeze, and so we want to make sure you can still continue to pee without having the device turned on. If we turn it on accidentally and you can't squeeze or can't find the pump, then we're in a little bit of trouble, and we may have to bring you back to the emergency department. So artificial sphincter, patient satisfaction, 94.6% are satisfied with their device. 90% are satisfied with the long term. And 90% of patients would have the surgery again, and 94% of the patients would recommend the device to a family member. And so this is usually if someone was in a similar situation. Insurance coverage varies. I will tell you this generally gets covered better than penile implants, simply because most insurance executives don't like the idea of being wet. Incontinence treatment is commonly covered by insurance. Coverage may be available under Medicare and Medicare Advantage, and those tend to be easy to work with. Don't let the cost be a barrier. Talk to your specialist. We can work with your insurance company. We can verify your benefits. Again, the VA is one of the ways we sometimes will, the veterans benefits as well as Medicare tends to cover this. And of course, this company has financial options for loans that you can repay. So what do men say about their implant experience? Herschel diagnosed with prostate cancer, got an artificial sphincter. It took me from 9 pads a day to 1. I wear 1 pad because I like to laugh, and it makes me feel like I can do things I want to with the confidence of not having to worry about wetting myself. Fabio, recovery was very easily. It took me about a week and a half where I was walking around without any pain. Walked the first week, no scarring. No one can tell it's there. So these things are discreet, and they're designed that way intentionally. Uh, so in terms of stress incontinence products, the ability to achieve continence, urinate when desired, place the entirety inside the body when it's undetectable to others, or where it's undetectable to others. High patient satisfaction rates, and then the key thing here is normalcy. No longer do you have to be able to drive to a place and know where the Quick Trip is, or the other gas station, or the supermarket is, to where you can stop off and change your pads, or potentially even change your clothes if you run into trouble. As a surgical procedure, there's always possible risks with any surgery. Not all patients are candidates for the male sling or AUS, so we'll discuss your risks and benefits for each of these in more detail with your doctor. Male sling side effects can be device failure, urinary retention, being hard to pee afterwards, postoperative pain, irritation of the wound site, and then a foreign body response where your body kind of gets reacts to having the implant material there. Artificial sphincter side effects, but not are possible, but not limited to device malfunction or failure, which may require revision surgery. So you may have to have another operation if it breaks. Erosion of the urethra in the cuff area. This is ideas of the ring around it eventually kind of cuts its way through, causing a pressure sore there that has to be, we have to remove the device. Urinary retention is having difficulty peeing after surgery, and then infection, pain, and soreness. So just in summary of stress incontinence, please know the side effects of prostate cancer treatment. There are a variety of options. Short-term options can be expensive and uncomfortable. Sling or AUS could offer a more long-term solution. To find out more information, go to fixcontinence.com. This is just a copy of references. And this is our general number. I'll take any questions. I see there's one in the chat. If anyone else has any other, recommend we get those. And then